Welcome to Let's Talk Micro. Hello, everyone. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. And you can always find Let's Talk Micro on Apple Podcasts, Spotify, Amazon Music, Google Podcasts, TuneIn Radio, GoodPods. Wherever you listen to podcasts, you can find Let's Talk Micro. As far as social media, I am on Instagram, TikTok, and YouTube as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and I have an email address which is letstalkmicro@outlook.com. So please go ahead and subscribe to the podcast, download episodes. If the app allows you to leave a review, please go ahead and do so. And if you have any feedback, any topic suggestions, you can submit those via social media or via email. Any feedback, any suggestions, they are always welcome and appreciated. And if you haven't checked out the previous episode, please go ahead and do so. I went ahead and went over MALDI-TOF, like the components, explaining all the parts, how does it work, how does it help in clinical microbiology. And some of you that maybe have been following me since I started or maybe early on, you know that I did a 2-part series on MALDI-TOF 2 years ago. But I thought that sometimes, with new followers and people maybe start listening to the new episodes and maybe not going back to the old content. And I did a webinar with the ASCLS about MALDI-TOF, and it is a trending topic, so I thought it would be good to maybe talk about it again. That way the new listeners can benefit from it. Maybe now the new listeners, they are either starting a class in microbiology, maybe they're starting a medical laboratory sciences program, maybe they just got a job in microbiology. So definitely, bottom line, it was a good time to talk about MALDI-TOF again. So check it out if you haven't done so already. And stay tuned for a second episode of MALDI-TOF where I will be talking about the advantages and disadvantages. It's a wonderful technology. It has helped out so much in the lab. But unfortunately, it has brought sometimes, some disadvantages. It has changed the way of thinking and sometimes, not for the better. So I thought it would be a good time to also talk about that. So stay tuned for that episode. So as you know, there are some wonderful microbiology podcasts out there besides this one, right? And I have the fortune and the chance to collaborate with them. And their content varies from the microbe moment, where they go, they focus on the historical perspective of organisms for the most part, and then you have like Microbe Mail. Well, they talk about antibiotics. They talk about organisms. Then there's Febrile with Sarah Dong. She's a pediatric infectious disease physician. And then there's the Infectious Disease Insight of Two Specialists podcast, or as it's abbreviated, IOTS, which they're based in the UK. They go over organisms. They both of them, Jame and Callum, they are infectious disease physicians, and they go over organisms, and then they go over antibiotics too. So definitely, it's a very successful, very famous podcast. I think they're doing really well, getting lots of downloads. And I had the chance to talk to Callum a while ago, and this time I got to collaborate with both of them, which is what this episode is. So you can actually find this episode on both platforms. They released theirs earlier than I'm doing. But bottom line is, once you finish listening to this episode, continue checking Let's Talk Micro, and then go over to their podcast and check out their episodes. They have some great content as well. I do listen to some of their episodes. A lot of times, if I'm going to do one that's the same content, I don't until I do mine. That way to kind of reduce bias. But overall, this is a great episode. And we went ahead and started talking about, requisitions in the lab. Like things like what are we expecting to see in lab requisitions? What physicians should be adding. We should see things, like the source and things like that. We talked about prolonged incubation. If there are things where we maybe need to prolong the incubation. We talk about media and how do we apply our thinking, and based on the source, do we add extra media? Is this something that it's done from the beginning, or is it done on the reading side? So overall, it was a great conversation. It's always, great chatting with fellow microbiology podcasters. So I hope you enjoy it. Let's go ahead and listen to it.
Hi, everyone. Welcome to the IOTS podcast. That's infectious disease insight of 3 specialists. I'm Jame, that's Callum, over there's Luis, and we're going to tell you everything you need to know about infectious disease.
Soon may the editing come to discontinue the Tazo sun. One day when the CRP's done, we'll take our leave and go.
Callum, how are you doing?
I think we need to talk, Jame.
About what, Callum?
Let's talk micro.
Let's Stop Micro, but isn't the host of Let's Stop Micro on the line?
Hey, that's me.
Luis, how are you doing?
I'm pretty good. Thank you for this opportunity to be talking to you. I mean, it's actually really nice. I had a chance to before to talk to Callum, and so it's great that I get to talk to both of you. So.
Yeah, no, it's real nice to finally put a face to the name and the voice. We should introduce each other's podcasts. Luis, why don't you tell us a bit about the Let's Talk Micro podcast?
Well, the Let's Talk Micro podcast, I started over 2 years ago, and it always came from this need to share information, to talk to people. I always enjoy it from training biomedical science students, which here we call them medical laboratory scientists. So I'm always like to talk, and I always give people more information that they need, and I'm pointing to people, hey, look at this package insert or check out this book. And at some point in time, I decided, you know what, just let me talk about it. And I started thinking about a podcast, and it seemed that it was a little bit difficult getting started. But then it turns out that when I slowed down and I did the research, it was easier than I thought. It was just, there are many providers out there. So it's just about recording, getting some cover art, proper equipment. And then I started. And it was also about, as working on the bench and seeing cultures day in and day out. You start microbiology, it's all about roots, and you start seeing things over and over again, and then you start noticing, wait a minute, this organism maybe is growing on this agar that is not designed for it, or it's like a back end, or you're short on supplies and you want to recover this, but we don't have it. So what can we use? So all those little tricks I started, noticing, and I'm like, okay, I want to share this with you.
And Luis, who's your main audience, and do you have any idea who's listening and who's tuning in?
Well, my main audience, so when I started, it was definitely mainly targeted for the medical laboratory science students, and then professionals as well. So it's just there is so much information in this field, and then working day in and day out, it's training happens quick, and it's very gray a lot of times. You have to know all this information about these organisms, their flora or their pathogens, and based on the source and things like that. So I just want to make sure that they had a better access to it and they could understand it a little bit better. But as I went along, I find out that I'm also getting, like directors, they're listening to the podcast. I have people in the industry, pharmacists. I went to a Microbe 2023 recently in Houston. It's for the American Society for Microbiology.
Oh yes, I saw that on Twitter, and you were a roaring success, I saw.
Yes, no, it was great. I really met people presenting posters. I handed little stickers with QR codes so people could go check out the podcast. And I get recognized a few times, and some of those were actually people like, that were pharmacists and directors. Are like, oh yeah, I listened to your podcast. Or are you Lewis from Let's Talk Micro? And that's the first time, it felt a little bit of a Hollywood feel, like here I am being recognized for something I do. Because you sit here, you record, and you're not doing it live, so you don't know who's actually listening to it. So actually putting some faces to the listeners, it was a great experience, and I enjoy this. I mean, even if I only had one listener, I will still do it, because it's just, I feel like even just talking about it and doing research, I'm improving myself. I mean, I'm trying to keep current with the resources, with the information, and just I feel that since doing this, I have grown so much, professionally, like my knowledge, that it's really great.
Speaking as maybe I could be that one listener, because we were saying before we started recording that I'm revising for my Part 2 fellowship exams, which if you are trying to sit, we've got an episode about how to revise for that, so go back and have a listen to that. And I've been listening to a lot of Let's Talk Micro as revision. It's been really useful, so thanks again for doing that. And would agree with that feeling of when people come up to you and say that they're a listener. That's a really nice feeling, just to know that there is somebody out there listening and that people appreciate it. So, Jame, what's the Idiots podcast? I've not heard of that one.
Well, I'm glad you asked, Callum. The Idiots podcast is the UK's premier infectious disease podcast. Started again 2 years ago. A lot of ID and microbiology podcasts seem to start 2 years ago for no particular reason. And we are focusing on the kind of the basics of infectious disease that a core infection trainee would want to acquire in order to be able to pass their UK exams. So our initial focus was kind of very much on doctors training in infectious disease or microbiology in the UK. But much like you, Luis, the audience has turned out to be much greater than that. So we did an audience survey recently, and it's about 2/3 doctors, but 1/3 everything else. So anything you can imagine: biomedical scientists, nurses, you name it. So we've kind of realized that our audience is a bit bigger than we had thought, which is great. The more people that know about infections and how to deal with them, the better. But our sort of core mission is really to, at least for the first few years, is to kind of develop podcast episodes which function as resources for people to learn about, all the bugs, all the drugs, and when we get bored, we all talk about certain clinical syndromes or do a journal club episode or just talk about a topic on infection in general that tickles our fancy. Isn't that right, Callum?
Yes.
Thank you, Callum. So on to the questions, eh? So what are we talking about today, Callum?
2 main strands. And the first strand I thought it would be useful to talk about, which we've not talked about in Idiots, and I think you've covered on Let's Talk Micro. And I guess our question would be, for those who are listening who aren't aware, who don't work with a medical lab scientists group or with biomedical scientists, or who aren't in that group, what is a medical lab scientist or biomedical scientist? What do they do? How does one become that? Like, what training do you have to go to get to that stage?
That is a great question, and before I answer it, I just want to say that thank you for listening to the episodes, and I have listened to yours, and this is one of those things that, and we talked about a little bit about it before, but as I was looking for other podcasts, and then I found yours, and as a medical laboratory scientist, and I'll talk about what we do, but we don't have much interaction, with infectious disease doctors. We typically just, what we see is like a request to work something up or maybe a quick phone call. So it's always interesting seeing what happens, right? We work with the results and we put them out there and seeing how, the treatment, the choices, for me, just connecting those two, it's great. So just like you said, a biomedical scientist, medical laboratory scientist, a lot of people are unaware of what we do, and this is something it's an ongoing struggle. I mean, you people typically, they're already about to graduate college, or they have already a degree, and then they find out about this. Maybe they know someone that completed this degree. So when you think about it, right? So you go to the doctor, and then they collect a sample. Could be, right, throat hurts or anything like that, cholesterol. You're getting, checking your hemoglobin. So that is tested. Those results, if they are tested, that sample is tested by a medical laboratory scientist, biomedical scientist, and a medical lab scientist. So that's what we do. We process those samples, and then we actually do the testing on it, and we produce results. So it can be, there are 4 main areas. You have blood bank, where we do the type and screen, for your units, your ABO. We do antibody screens. Then, you have hematology, where you do, hematocrit, hemoglobin, you do cell counts. You move on to, there's clinical chemistry, where you analyze glucose, cholesterol, hormones. And you have microbiology, where we do PCR testing, and we test for viruses, bacteria, fungi. So me, as I have worked in all the other areas, but I don't know, and But let me just go first with the education. So there are some variation, but you can work in this. The main one will be a bachelor's degree in medical laboratory sciences, and then you have different programs where maybe you do 3 years of undergrad with some required courses, and then your final year it's in laboratory, that or you have the 2 and 2 where you do those 2 years of undergrad, and then the last 2 years they are related to the lab with a clinical rotation. Or you can also, some programs they require that you already have a degree, like in biology or chemistry, with some required courses, and then you do that 1 year of like didactic and laboratory, your clinical rotation. So yeah, so that is the training, and then I touch on the other areas. And for me, as a medical laboratory scientist in microbiology, we do all sorts of testing, all sources. So we do from from PCR testing, any type of rapid testing like influenza, Streptococcus pneumoniae, rapid strep, PCR and group B strep, and then I concentrate heavily on working on culture. So those samples they're plated on agar, and then we look for the presence of organisms, and then based on the source on the organism, we produce identification and do susceptibility testing. And then we have to make the determination, the organism that's growing here based on the source, is it a pathogen or is it part of the commensal flora? And with the susceptibilities, right, make sure that susceptibility pattern matches to the organism, do any extra testing that is required. So it's great work, and I love it, and I recommend it. And I think that we are making progress. And some medical lab sciences programs, they're going out there, they're going to high schools, they're going to colleges and promoting the field. So it's an exciting time.
Luisa, I have to ask at this point, I've wondered this for years. What is your day job? Like, what are you doing day to day? Are you on the cultures benches? Are you supervising?
Yeah, so I was a supervisor for a little bit, and it had its good things and then these not so good things. So ultimately, I ended up not being in that position anymore. As of right now, I am a lead medical lab scientist, and I am in charge of the quality control of the microbiology lab. So everything from agar, from testing, I make sure that we're complying with the requirements, that we're doing either performing the QC, either like a lot shipment, make sure the agar, if it needs quality control, sterility. But I do work on the bench, and I do work with cultures from pretty much all the areas, from wound cultures to urine cultures. So I'm all over the lab and do a lot of susceptibility testing. So as of right now, I'm still heavily involved. So that will be my main job. And then as a part-time job, I work as a laboratory instructor at a medical laboratory sciences program here in Florida.
Excellent.
So thanks. I hope that makes it clear, because I think sometimes, certainly as a clinician prior to training in microbiology, I don't think I really understood that aspect of the role. And I think that aligns pretty well with what a biomedical scientist in the UK does. It's a really skilled job and require a lot of training to get to the point of being able to do that. And we really rely on that expertise in the laboratory. I guess the second part of what we wanted to speak about is kind of related to that, I think. It's about the interface between clinicians and the laboratory. And I think this is something that can be a bit tricky, because when you're asking for something, if you don't understand how the thing is done, it can be a bit tricky to know what you're asking for, if that makes sense. So I guess what I mean by that is, if you're requesting a test, if you don't understand how the test is performed and what factors changed the way in which the test is performed, you might not request the test in the right way. I think there's a book recently published called How to Request a Test, which I saw and haven't read yet, but one of my colleagues said was really useful for this question. So I guess, Luis, I would like to just talk about a little bit about that part of the sort of pre-analytical phase. So how tests are requested and how that influences what happens in the lab. So I guess the first question is, as a medical lab scientist, what do you look at in the specimen request details? what information are you looking at when you're going off to do, let's say, a throat swab or some other investigation?
All the way from the ordering, that's a challenge that happens in the lab, and sometimes we have the issues with the laboratory information system, and where sometimes we get providers that order everything, or there's a catalog of tests and maybe some that are not done at our hospital, but they order that one, and we have to work with that and check with them and make sure that offer the one that we do in house, or they want something else, to let them know, and then notify them, and then send that sample away. But whether it be like a paper request or you get it, electronic, so we definitely, want to make sure that, of course, right, the patient identifiers, we want to make sure that it's properly labeled, that you have the information that it needs with the the addressographic information of the patient, name, date of birth, and that we with the sample as well, we want to make sure that our sample it's labeled with all that information, not just one last name, right? It's just only one name. That's just very difficult, and if it's missing information, unless it's like a critical sample, an irretrievable sample, right? If you get a cerebral spinal fluid label, I mean, we have to call them, and then we fill out a form explaining what happened, and then the sample is labeled. But if it's something like, let's say, just like a blood tube or something like that, then we just completely reject it, and that sample does not get tested at all. So proper labeling, that's the first thing that we have to make sure that we do, right? We're definitely putting a result out there that's going to go to patient's chart, and that's going to affect the course of the treatment. So if that result is erroneous, we're putting that patient in harm. So that will be the first step. And then also, we're also looking at, right, what order, the source of the sample. And that's a big one. Many times I find myself working on a culture, and then it just says sample source, and it just says wound. I'm like, okay, it is a wound, right? I'm working on the wound bench, and it's always, it is a wound, but I need to know where. Many things change depending on the source, right? You wouldn't treat the same, let's say, a sample that's maybe from enteric area, like from another source, right? You have a lot of enteric bacteria. You consider that into factor. If you start seeing multiple, let's say, enterobacterialis in that area of the body versus an arm wound or something like that. So the source is very important. You want to know, right? If you have something respiratory, you start seeing, let's say, start seeing maybe like Icanella or things like that. Or so it helps you correlate that with the culture, and it makes you make the proper determination when you are working it up. And for those of the listeners out there, when you call it work it up, it's just, you are evaluating the culture, you're seeing the organisms, and then you're making that determination. Okay, I have here, normal skin flora or a pharyngeal flora or something like that. Or if you have something like, like Staph aureus, E. coli, Pseudomonas. So we definitely need to know the source. That's very important. And then the other thing is, and maybe is also, collection time. It's very important. You want to make sure that, because it's just, sometimes, that you have, like, a great example is when we used to do the occult blood, test for the stool, that we used to get the 3. And then they don't put the collection time, or they put it and they're all like maybe like a minute apart. It's like, well, that doesn't count. You're just not making the proper evaluation. It's just, that sample is probably from the one time. So that's also something that's very important. And if you are suspecting anything, that's just a potential, that it's just an organism that normally, like it's either a potential bioterror agent or that is very abnormal, please let us know so we can start taking the proper precautions. But yeah, those are the things that we look at. And just to touch a little bit on what you mentioned earlier, with the biomedical lab scientists, one thing, and at least here in the States, is sometimes people think that, that you just do a bachelor's in microbiology and that just guarantees you, a job in the lab. And that's not the case. You do have to go through one of these medical lab sciences schools, like a program, and get a certification.
Yeah, it's a complex journey to get there. And I think that's, probably a global issue amongst every lab, isn't it? That you're getting samples that are incorrectly labeled. You don't know who they're from. You're having to reject them, and nobody wants to be the person that says, we had to reject the sample, particularly if it's a precious one. And every effort is made to try and do that. But when you're dealing with thousands of samples, or that's not safe to process it, the worst thing that we could do is release a report and say your patient's got this pathogen, and they don't. So that that could be really bad if it was accepting poorly labeled samples. I guess the other thing that came to my mind was there's some clinical situations, I think, where actually the clinical details change what's done in the lab. What is there any examples of that the of you can share? The one that comes to mind for me is that I learned about when I went and did the bench training, the brief bench training that I got to do was that throat swabs. So if you send a bacterial throat swab to the laboratory, and if you put on it that the patient had recurrent tonsillitis, and then it might get worked up for a different organism, or if they had long-standing throat pain, then we might work up for something else. So I think it was Fusobacterium necrophorum was one, and the other one was Arcanobacterium. Correct me if I'm wrong there. So I found that really interesting because as the person who had previously been ordering the throat swabs, I had no idea about that. And I wonder if that was a little bit of a failing of our ordering system, in that it didn't allow you to, it didn't prompt users to say what's important. Is that something that's reflected in your area of practice, or is that something that isn't an issue for you?
Yeah, we had some issues, and I know that there are some restrictions in place. I think it comes when I mentioned that when ordering that are called blood tests, and also when I think there's one for blood cultures as well. I think one that wasn't a prompt, and then we tried building one, was for ordering parasites, like ONP exams, and because we were getting so many, patient with diarrhea, just collect a sample, and then we were getting so swamped, and then we built some restrictions, that the physicians had to answer, like, is there like a travel history and some other questions, and they were able to answer all three, then the system will let them order the test. And that worked well for a while, and then we switched to another system, and the restriction, I guess it wasn't updated with the system, and we started getting that flood again, and we're working on it. Those are the two that come to mind. But as far as other things with history like that, that's mostly something that we do look out on the side, that when we're actually working the cultures. I mean, as part of our standard work, we check the history, see if the organism is the same, and then depending on the source, if it's within 48, well, we do 72 hours, we can refer the organism to the other one, and then just not perform a susceptibility on it. We just have to make sure, right, that in cases like if you have Staph aureus, you have to make sure that either they're both MRSAs or they're both MSSA. You're going to do that type of thing of referring the susceptibility. But we do keep an eye on the history, and typically if we see that there is a patient that has a history of an MDRO, we kind of just start setting up the reflex ahead of time, just to save a day, because we know it's well documented there. Or if we see in the history that there's an organism, we make sure that we go ahead and add an extra blade if it needs to, or maybe if it needs to be incubated longer, we do that just to make sure we don't miss it.
Luis, what clinical information would make you want to put a culture in for prolonged incubation these days?
Well, one definitely one that's big. It's if we have, let's say, if patient with like a history of nocardia. We definitely want to make sure that we keep, or if there's no history, I mean, if we do see the gram positive, like the beta rods on the initial gram stain, and maybe right for a little bit for later out there, if as I talked about what we do in the lab. So right initially we get that sample, and then we put it on the agar with some nutrients, and it has the conditions that the organisms need to grow. And we also perform a gram stain, which will be the direct smear. And if we see anything like that, we just kind of make sure that we seal the plates, and then we notify someone and make sure that we hold them for 7 days. And so that's a really big one. The same thing we have, if we have sometimes, like a mold, or make sure that, we're kind of looking out for it if we need to add an extra plate or hold it longer. So those are really the type of scenarios that we encounter the most.
Yeah, I think it, there's this whole there's definitely a gulf sometimes in knowledge between the clinician and the laboratory in terms of knowing what's going to be processed, and that's not going to be the same for everybody. And I guess at points I've felt like, oh well, often the request details that we get is just like blank, so just the space, or people say like monitoring, or they don't really give you that detail that we need in order to process the sample right. But more recently, I think I've kind of changed my mind on the onus being on the user, and actually, it's kind of difficult to know when you're ordering a test if you don't understand the laboratory, and it's not. I don't think it's reasonable for us to expect everybody to have a full understanding of what's actually happening, although I would love that. So maybe the onus is more on the laboratory as a whole to design systems that mean that when you're ordering a test, it forces you to answer the questions that we want answered. So if you're ordering blood cultures, it forces the user to say, okay, have they been to any areas that are sort of tropical areas? Is there any risk of typhoid? I guess is what we want to know. And these sort of questions, which are really important for the lab, but the clinician might not think to have even asked the patient or include in the specimen request. So I guess on to the next question is there like key safety information that people should be putting onto requests? And if so, what is that?
Yeah, definitely. And before I move on, this came to mind as I was listening, and we also before in the past, with a previous blood culture system, we used to hold them, and we got physicians requesting to hold the cultures. So sometimes 14 days to make sure that we didn't miss like a nutritionally deficient strep or the same thing, hold them longer for brucella. And one of the requests that we get a lot is for cutibacterium to make sure that we hold them 14 days. And that's something that we do with like sources that are like from the knee. We definitely hold them for 14 days, but we still get those. As far as the blood cultures with the systems, some of the systems out there, a lot of these organisms, they're detected very fast. So really the prolonged incubation time is not necessary. And the pathogens, we do get them. I mean, cutibacterium, it really, on a blood culture, especially, it pops positive about day 4, 3 to 4 on average.
Yeah.
So we do get them. So those are not necessary, but we still get a lot. Sometimes, we do get the request, especially if we have sometimes, maybe I was in like old school physicians, and that sometimes, they order some tests, the way that they were before and things like that. But yeah, those are the ones that come to mind. But as far as precautions, if there's a history and a great example, and I talked about this before on other podcasts and with other people, a lot of times that we had like a brucella exposure, sometimes, they kind of were thinking about it and no one said anything. So, and just to give some background to the listener, right? So when we're working the plates, right, we typically, so we go ahead and we try to identify them, right? We're not getting that ID. So the next step is, right, okay, well, maybe let me consult with a more experienced coworker. So you do that, and then that person looks at the plates, and then, or maybe, okay, let me check with my lead or my supervisor. So bottom line, sometimes, you have 4 or 5 people looking at this plates. And then all of a sudden, it's like, okay, it turned out to be brucella, and everyone is, being put on prophylaxis and things like that. And then we find out that they kind of knew. So if you're suspecting anything, and that comes around, right, when you're taking the history of the patient, and you're thinking there's some travel history or something like that, and you think that maybe, be on the lookout for this. If you are able, if you're thinking about that, if you're suspecting it, please let them know, because, it changes the way that we treat the sample, right? So it goes back to, we get the samples, we plate them. Most of the plates that we work, here in the micro lab, we work with them in the open. I mean, we use our PPE, we have our gowns, we have our gloves. We should, I think some people, maybe some that have been working longer times, don't do that, and that I don't like that, but we definitely have that. I mean, with COVID, I think more people start incorporating wearing the mask. So
Yes,
we take those precautions. But if you tell us, you're thinking about that, we immediately, from the moment that we get that sample, we We go to our BSL2 or BSL3, and then we just go to that, and we go to the BSC, and then we process the sample under the hood. We make sure we keep everything there, we seal it. So we will handle it differently than you just having, waving that plate around for 3 or 4 days, and then all of a sudden, it's Brucella. So with experience, since we function as a reference lab, when we get a plate that says, maybe like gram-negative coccobacilli for ID, we're kind of careful to make sure that maybe go to the hood and open it there. And if you see tiny growth, just proceed with caution. But bottom line, if we got those warnings ahead of time, if they put it on the request, it will definitely change the way that we treat the sample.
Yeah, it's hugely important. I was just, as you were saying that, a voice popped into my head and it said, "Don't sniff the plates," or "Don't smell your plates. Stay safe." I heard that on a podcast somewhere. So maybe you should have that on a t-shirt. I don't know if you're getting merch, but I think that whole lab safety thing is really important. And I do think, Jane, that maybe you've already done this, Luis, is have an episode about lab safety. In the UK, we've got this group called the Advisory Council for Dangerous Pathogens, and they publish a list called the Approved List of Biological Agents. And they categorize pathogens into groups 1 to 4, with group 4 being the ones that are very serious and cause serious hazard to employees, that usually likely to spread to communities, no effective prophylaxis or treatment available. And all organisms are categorized into one of those 4 groups. And the way that the lab works, if there's risk of these group 3 or 4 organisms, then you process a sample in a different way. So it's really important for the team to know that information, and they won't know unless it's in the request detail or someone phones. So yeah, I think that lab safety aspect is a real key consideration as a microbiologist in the lab or the clinician that's ordering the test. So Luis, is there anything else that you would say, any other examples of things that you would change in the lab if the clinical details said one thing rather than the other?
Yes, yeah, definitely. The orders, they change from lab to lab, and there are some things that kind of just maybe remain standard, right? Maybe a wound culture, or there might be another phrasing to it. Some places maybe they call it like miscellaneous, and then when you think about your standard setup, for most, if you're doing like urine cultures, right, you do blood and you do McConkey, and then if you have a regular culture, you do blood, chocolate, and McConkey, which for the listeners out there, depending on where you are, if you maybe are training or you're starting to learn, right? So it gives pretty much all the organisms a chance to grow. It gives the gram negatives a better chance than the McConkey. You're getting your fastidious with the chocolate, and then the blood pretty much grows everything. But if we see something like doors, for example, let's say there are genital cultures in the lab where they get like a limb broth or chaudhry for group B strep. And then there's also a Thayer Martin for Neisseria gonorrhea. So if we get, let's say, a wound culture that the source is genital, then we go ahead and we add that Thayer Martin plane. A lot of times, and this is not on the request, but definitely if we're working like a blood culture and we see both gram positive and gram negative, we throw a PEA. If we see that there's a history, maybe a mold, we can just go ahead and add some fungal media just to kind of make sure that we're giving the organism a chance. I mean, you don't know, maybe on the gram stain you can tell, but you don't know, if it's going to be like a polymicrobial infection, and you might have a lot of things on your plate. So at the very least, you take that caution, and by adding those plates, you're giving those organisms a chance if they are there, so you don't miss them.
Thanks. I think it's a really key part, is that like how much the details in that pre-analytical phase, like before the lab work starts, can affect what it is. Because if we don't know the clinical details, then we won't know what extra plates are set up to look for organisms, and you might miss something. And then the clinician gets back a result saying culture negative, and they relax. And it was interesting what you were saying about some of those older school clinicians asking for specific things, and maybe they're a bit out of date and they don't actually know what the standard lab practice is, but at least they're engaged in the process, and at least they're thinking about asking the lab for extra things. I think for me, one thing that I find really helpful is there's the UK Standards for Microbiological Investigation, the UKSMIs, which we've certainly spoken about before. And just thinking of two examples, so SMI 11, investigation of swabs, some skin and superficial soft tissue infections, they lay out that everybody should get blood agar and Cled or McConkey, and then they say add in different agars for different things. So if it's a traumatic wound, add in a plate for anaerobes. If it's a cellulitis from a human animal bite, add in the chocolate agar looking for Haemophilus. If it's a burn patient or diabetic or is into Trigor or Paronychia, add in the Sabaro agar for yeast and mold, and etc., like Hoyle's agar for diphtheria. And another example is in the context of SMI 17, which is investigation of tissues and biopsies from deep-seated sites. There's so many supplementary agar that they suggest, and also like some of the growth conditions are different. If you're thinking about things like nocardia or tino organisms, branching gram-positive bacilli, which we did an episode on. So it's really important, and I think for those precious samples, there's probably someone in the lab thinking about it, and there might be a clinical microbiologist looking at the patient's notes or speaking to the clinician and saying, like, what do you actually want done on this? So actually, maybe it's even less important for those critical samples. It's more the routine ones. I don't know if you agree with this, but like the ones that, just go through the lab very quickly, maybe that's where it's more important to say if you want something specific. And then the unusual specimens, then we tend to pay a bit more attention to those anyway, because they're a bit more rare.
Yeah, we do. And this, it's something that definitely we do pay more attention to the unusual ones, and then from the routine ones, sometimes things do get missed or they get delayed. We get that many samples, and this is something that, we were telling the provider, make sure that you're putting all this in, and then on the lab we should be able, to question this. And a lot of times, they just, the moment that you get that requisition and something is missing or it doesn't match or something like that, just make sure that right away you talk to the physician, you let them know, so it can be corrected. Sometimes we catch these errors and things missing 24 hours later when we were looking at the culture on the plate. We end up delaying patient care to have all the information. So it just it takes the effort of everyone, really, from that pre-analytical phase, right, from when the sample is collected and we get, and prior to testing, and then the analytical and post-analytical. So if something starts wrong from the beginning and it's missing, then it's just the whole thing kind of gets a little skewed, and at the end, it's just the one that gets affected, it's the patient, because we're delaying the results. And I said this over and over again, right? Micro, it's all about time. So something goes wrong and it costs you a day. And yeah, it takes a lot of teamwork and communication between all parts.
It's a key point, well made, that at the end of the day, everyone's aim is to get the best result for that patient. So giving the clinical details is really key to us getting there. And the lab is often a really high throughput place, and there's not time for your medical lab scientist or biomedical scientist to be chasing up every time the clinical details aren't complete. It's just not feasible. So if you want as a clinician, if you want your patient to get the best possible investigation, then you really need to put those clinical details in. And I think as a lab, or a lab manager, maybe you should be thinking, how do we make it easy for people to provide that information? How do we mandate the questions? Because we know the questions that we want answered, but we don't know the answers to them. And the clinicians know the answers, but they don't know the questions. So we need to find ways for the questions to be asked and answered. Does that make sense?
Yeah, it does. And always be receptive to feedback. So if you're in the lab and you hear suggestions, be receptive, and the other way around. So if you feel that there's something better that can be done, by always, right, don't be afraid, just bring it up. And all they can say is no, but that's it. And
you don't ask, you don't get. And garbage in, garbage out as a computing term. But if you put bad information in the beginning, then you're going to get a bad result out at the end. Jame, do you have anything to add? I think this might be the episode where you've spoken the least.
The knowledge getting dropped on us, Cal. No, I don't have anything to add. Louise, thanks very much for coming on the show.
Yeah, no, my pleasure. So, but definitely, thank you for the opportunity. And like I said, I listen to your episodes. It connects what happens on the other side. And yeah, so to your listeners, if definitely I'm always very reachable, and via social media or email. And once you have listened to the idiots episodes, take a look. Let's Talk Micro, and on Instagram, TikTok, and YouTube as Let's Talk Micro, and what is called now X. We're all still getting used to that. Let's Talk Micro One, yeah, and then an email, which is Let's Talk Micro at outlook.com. So any suggestions, any feedback, if you think that you have a good topic and you want to reach out to do an episode, I'm always receptive to that. So yeah, please feel free to reach out.
Brilliant. All right. Thanks for coming on the show.
My pleasure.
Questions, comments, suggestions, send them into idiotspodcasting@gmail.com. Have a 5-star review in your pocket. Callum and I would love to have it. Lewis would also. Please drop them in your podcast players of choice. We X at idiots_pod. And if you want to donate to support the show, there is a link to do so in the description. But until next time, I'm Jame.
And Lewis.
I'm Callum. Thank you for listening to the Idiots Podcast, the UK's premier infectious disease podcast. We are supported by the British Infection Association, but they do not have creative control over the episode content, so please don't blame them if we get something wrong.
Questions, comments, suggestions? Why don't you send them into idiotspodcasting@gmail.com. Have a 5-star review in your pocket. Callum and I would love to have it. Please drop it in your podcast player of choice. We tweet at idiots_pod. And if you want to donate to support the show, there's a link to do so in the description. But until next time, I'm Jame.
I'm Callum.
See you then.
Now that the episode's done, we hope you learned and had lots of fun. So go forth and treat people with some of what you now know.
Do you have any crap puns that you didn't include in the show proper?
No, I've got no puns about feces. But what I would say is that after we recorded, I realised that we didn't even mention that both the podcasts would be supplementary to each other. And they would particularly be enriching to listen to both episodes, particularly where there's overlap. Although I guess with the limited time that people have for training, maybe you can be a little bit selective about which episodes you listen to.
Ding, 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 ding. That's Agar Bingo.
And that, my dear audience, is the end of this episode. I hope you enjoyed learning about, laboratory requisitions and things that we are looking for, learning about samples and things like, like adding more media, prolonged incubation, things we do in the laboratory. They're part of their job, and how, how can maybe they can be improved. And, sometimes, right, we need communication from the physicians and the lab to make sure, right, what are they looking for, and at the same time, us saying based on the procedures that we follow, the things that we do, the things that we don't. So communication is essential. So stay tuned for the next episode on Malditov, about the advantages and disadvantages. As always, definitely great talking to Jame and Callum. Wish you the best. And I hope, that we get to do another collaboration. So, as always, continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.